Uh, Dear physicians and medical students, welcome you all. Very good morning. আজকে আমাদের ইসিজি সিরিজের পঞ্চম ক্লাস। আজকের টপিক হোয়াইট কিউআরএস ট্যাকিকার্ডিয়া। আমাদের মাঝে যথারীতি আছেন আন্তর্জাতিক খ্যাতিসম্পন্ন ইলেকট্রোফিজিওলজিস্ট ডক্টর রফিক আহমেদ। ডক্টর রফিক আহমেদ কনসালটেন্ট কার্ডিয়াক ইলেকট্রোফিজিওলজিস্ট, মেডস্টার হার্ট অ্যান্ড ভাস্কুলার ইনস্টিটিউট, বেলটিমোর, ইউএসএ। আমি আর কথা না বাড়িয়ে আমি স্যারকে আজকের সেশনটি শুরু করার জন্য বিনীতভাবে আহ্বান জানাচ্ছি। ডক্টর রফিক আহমেদ স্যার, প্লিজ।
Thank you. Good morning. Assalamu alaikum, Shawaike. So I think it'll be good, as we have done before, if we can make it a little interactive. So we're going to talk about white QRS tachycardia, VT versus SVT. The question is that if somebody has, we talked about narrow QRS tachycardia last week, and narrow QRS tachycardia, when we look at it, mostly this is supraventricular tachycardia. Now, white QRS tachycardia, on the other hand, can be, most likely it is VT, but it also can be that somebody has supraventricular tachycardia with underlying bundle branch block, and it gives rise to a white QRS tachycardia. And sometimes it's difficult even for us after many years of practice. So I'm going to show you one ECG. And I have given some choices. Anybody want to answer this question? This is somebody, he's a 44-year-old male, has non-ischemic cardiomyopathy with a heart rate of 200 beats per minute. No volunteers?
Dr. Mahmudul Hassan.
Sir, QRS complexes are regular. Heart
Yes.
rate is near 200
It
beats
is
per
200.
minute.
Yes.
And there is white QRS complex.
Yes. So I have choice. You can see my choices, like ventricular tachycardia, sinus tachycardia with underlying IVCD, atrial flutter with underlying left bundle branch block, sinus tachycardia with hyperkalemia. These are the choices. What do you think?
Yeah, my choice is ventricular tachycardia, sir.
Yeah. Okay. So I mean, if you give me this ECG, I will also choose ventricular tachycardia. It is a white QRS tachycardia. It does not look like any typical left or right bundle. But interesting part is, look at this second ECG. The same patient. This is January 8, 2005. Same patient. When the heart rate slowed down a little bit later, you can see that there is flutter. Can you see the flutter, Mahmoud?
Yes,
The
sir.
small piece. So now it's 2-to-1 conduction with exactly the same morphology as before. So this gives you an example that it may look like ventricular tachycardia. Sometimes it can be supraventricular tachycardia. So this flutter was conducting 1-to-1 before here and giving rise to what looked like ventricular tachycardia. Now, of course, if I did not have the other ECG, this ECG, as you said, if you say ventricular tachycardia, I'll have to accept that diagnosis. So, how about this one? Again, we have somebody with white QRS tachycardia with heart rate of 219 beats per minute. Anybody?
There is RSR pattern in V1 and V2, sir.
Yes. So what do you think? Heart rate is 219.
Sir, it may be SVT with RBBB.
Yep. So, I mean, one option is that this is small r, big R, like typical right bundle. So this can be SVT with right bundle branch block. If somebody tells ventricular tachycardia, I will have to accept it. But same patient, when the heart rate was slower on the same day, you can see has underlying right bundle branch block. So having an old ECG helps. So if I have this ECG and then I see this ECG, I'll say, yeah, this is supraventricular tachycardia with right bundle branch block. Thank you. How about this one? Anybody else? Dr. Javed.
Assalamu alaikum, sir.
Awesome. So the heart rate is, did I put the heart rate? I think it is close to
210.
210 beats per minute. White
So
QRS.
RR interval, white QRS complex with regular RR interval.
Okay.
There is a right axis deviation.
Okay.
And
What do you think it is? I gave you the choices, right? Sinus tachycardia,
Yes,
right bundle branch block, ventricular tachycardia, atrial flutter with bundle, or sinus tachycardia with hyperkalemia. What do you think?
ventricular tachycardia.
Yes. So why did you say this is ventricular tachycardia?
So white QRS complex with
Okay. Wait. White QRS complex. So that's the only thing you have, right?
yes, sir.
Yeah. So white QRS complex. So look at this. So what are the criteria? We can use different criteria. One of the criteria is the precordial lead concordance. Do you understand this term? That means if in the
Same
chest
direction.
lead in the same direction. If you look
Directions.
at V1 is positive, V2 positive, V3 positive, V4, V5, V6.
6.
This is precordial concordance. If there is any difference, then it will not apply. So this is, if we see concordance of the P wave in precordial lead, that is ventricular tachycardia. It's more or less certain. Without, and it can also be RSR pattern in V1, but it has to be one of these properties. So this is ventricular tachycardia. How about this one? Somebody else. Don't look at the rhythm strip below. It's after sinus rhythm. I'm looking at the white QRS rhythm, tachycardia. What is your diagnosis? It's about, the rate is about 150 beats per minute. Dr. Maruf Hassan.
স্যার ডক্টর আব্দুল আজিজ আব্দুল্লাহ উনি হাত তুলেছেন।
Okay, fine.
আব্দুল আজিজ,
Sure. Good. I can't hear you.
ডক্টর আব্দুল আজিজ, উই ক্যান্ট হিয়ার ইউ প্লিজ। ডক্টর আব্দুল আজিজ আব্দুল্লাহ।
Your sound is bad. Now, little better.
Okay, next one.
Who else?
Anyone?
So this is sinus tachycardia with underlying LBBB.
Sinus tachycardia with underlying left bundle branch block, right?
Yes.
Okay. So, who is speaking?
Sir, Mahmoud Hassan.
Mahmoud Hassan. Okay. So why did you say that?
Sir, there is a lead in V1 and V5. There is LBB pattern present, and
Okay,
there is
fine.
not.
Just one moment.
Yeah.
So V1 and V6 look left bundle. How about lead 1?
It seems to be white complex.
Yes, but if it is left bundle, lead 1 should have been positive, right?
Yes, sir.
Right axis deviation.
It is not. So even though the chest lead fulfilled your criteria of left bundle, V1 did not. But it is an acceptable diagnosis if you tell me, but only part is that lead 1 did not fulfill. So that goes out in a way. What will be your second diagnosis?
Then I will say, sir, atrial flutter with underlying LBB.
Again, same problem. Yes. So let's look at this. What is there? It looks like left bundle. So let's use some criteria to use. One of the criteria we use onset of R wave to the nadir of the S wave more than 100 milliseconds in any precordial lead. And look at this ECG. Just 1 second. What I'm talking about, from the beginning of QRS complex to the deepest point of the S wave in any chest lead. So what I did, I took V4. And if you look at this, from here to the deepest point of S wave, it is 3 boxes, a little bit more, 130 milliseconds. So if we left bundle morphology, it doesn't matter what morphology it is, beginning of the QRS to deepest point of S wave, if it is more than 100 milliseconds, that's ventricular tachycardia. And this one was 130 milliseconds. So your diagnosis is correct. So the reasoning will be that ventricular tachycardia, you said sinus tachycardia left bundle, it did not fulfill the sinus tachycardia left bundle type. It is ventricular tachycardia based on white QRS, and it fulfilled this criteria. So if it did not fulfill this criteria, can we use anything else? How about this one? Anybody else?
Dr. Mehnaz,
Who is speaking? Who will speak? Who is the volunteer next?
আজকে ইসিজি কি কঠিন লাগতেছে নাকি?
একটু কঠিন, but that's fine. No, these are difficult.
Sir, may I try, sir?
Yes, please
ওকে
do.
ওকে, আপনার পরিচয় একটু প্লিজ, আপনি আপনার পরিচয়টা যদি দেন।
Sir, Dr. Mahmudul Hasan, sir.
ও আচ্ছা,
Okay,
মাহমুদুল হাসান।
So this is heart rate 130. What do you
The
think?
heart rate 132, sir. Almost 132. I calculated.
Okay.
In
Regular or irregular?
Sir, regular, sir.
Regular. Okay.
Yes.
Heart rate regular. Narrow or wide QRS?
Sir, white QRS, sir.
Okay. Wide QRS. The duration is about 140 milliseconds. What type is it in the chest lead? Right bundle or left bundle type?
Sir,
Right bundle.
right bundle branch type, sir.
Yes, but look at lead 1 did not fulfill right bundle criteria. So what do you think this
Yes,
is?
sir.
What do you think this is?
This is junctional tachycardia with underlying RBB.
Okay, so your choice is junctional tachycardia underlying right bundle branch block. One of the things that it did not fulfill, one, with the right bundle, you should see a small R followed by bigger
Larger.
R wave. Larger. It is not, it is reverse. V6, it fulfills right bundle criteria.
Yes.
Lead 1 does not fulfill right bundle because lead 1, it should see a S wave. It did not. What else do we have? Let's look at something.
So it looks like flutter wave in lead 1.
Lead 1,
Sir, I don't think so, sir. Is it flutter wave, sir?
no, it doesn't look like flutter wave because to see any wave, it has to be a regular wave. I don't see any flutter wave, but let's look at this thing. So one of the criteria that we use to diagnose ventricular tachycardia is there AV dissociation? Do you understand this term AV dissociation?
So we have idea, but if you can elaborate.
Okay. AV dissociation means, think about sinus rhythm.
Yes, sir.
There is a P wave followed by QRS complex, right?
Yes, sir.
So there is an association. That means the QRS is associated with the P wave. If the P and QRS have no relation, and we have a rapid tachycardia, that will be ventricular tachycardia. Other situation that we see AV dissociation is complete heart block. Because in complete heart block, Yes, but that in that case, heart rate is slow. So let's look at this. You see this rhythm strip below. Look at this QRS. See my pointer?
Yes, sir.
The second one, there is something there.
Yes, sir.
And then,
Different from other.
okay, let's continue following. And you see there is another one.
Yes, sir.
Continue following it. You'll see another one.
Yes, sir.
And there is possibly another one here. And there is another one. These are the P waves. And these P waves have no relation to the QRS complex because these are randomly
For the
assigned.
dissociations.
Yes. So wide QRS tachycardia with every dissociation is present in this.
Ventricular
And if
tachycardia.
this is ventricular tachycardia, no question about it. There are other criteria also. We will come later on. You'll find that this ECG have other criteria for ventricular tachycardia. So thank you. So
Sir,
remember,
I have a question.
yes, okay.
So in case of complete heart block, there is PP distance is equal, and here the PP distance is not equal. So,
Okay, it is because some of the P waves are buried in the QRS complex. During ventricular tachycardia, most of okay, let's go back. You are asking a valid question. Like this one, I cannot see any AV dissociation. I cannot see the P wave because the ventricle is beating so fast. Even if there is AV dissociation, the P wave is probably buried in the QRS complex. So same thing is happening here, that it is very difficult to find the P wave in ventricular tachycardia because so if one here and one here, and then we do multiple, you will find they are buried somewhere. Like this one caused a distortion. If there is something in the middle, it will probably be in the T wave. That I cannot say where it is. So that's why it looks irregular.
thank you, sir.
Did I answer your question? In complete heart block, you will be able to see all the P waves because in complete heart block, there is QRS complex is slow, QRS rate is slow. So the P waves are distributed evenly. So in this case, AV dissociation was present. So it is definitely ventricular tachycardia. Okay. And this is another example of.
May I ask a question, sir? In
Yes,
relation to
please
third
do.
degree heart block. Sir, in case of third degree heart block, we know then there is a AV dissociation. There is no relation between P and R.
Yes.
Sir, it is said that RR interval is fixed in case of complete or third degree heart block.
Yes.
Sir, PP interval is fixed, or it might not be fixed, or something like that.
In complete heart block.
Yes, sir. RR interval is yes, sir.
Yes,
sir.
RR interval is mostly regular. PP interval will be regular, but there can be some variation depending on the intrinsic vagal tone. Especially even if there is irregularity of the P to P, there it is minor. Majority of the time it will be regular.
Can we say that there is no universal rule that PP interval will be fixed in case of third degree heart block?
PP interval, you need to understand something about sinus node function.
Yes, sir.
That sinus node function is never in one point. If you remember my first lecture,
Yes.
if you look at a 12-lead ECG, if you measure very carefully, you will find that very few patients have regular P to P interval. There will be some variation. It is mainly because every time we take a deep breath in, we influence the rate of the sinus. So there will be some variation. It is extremely unlikely that you will find a sinus rate which is strictly regular. It is not common. There will be some variation.
Yes, sir.
So this is another example. This is a little bit slower heart rate. Again, wide QRS tachycardia, you can see there is a P wave here. And there is a P wave here. How do I know this is P wave? Because it is not present here. But look at this complex. this complex is a little different from this one. And this is probably the fusion between a conducted QRS and the ventricular tachycardia beat. And we call it, these are fusion beat. And there is another fusion beat here. The P wave followed by QRS, which is midway between the sinus and the ventricular beat. And if we have AV dissociation and capture beat or fusion beat, that is more or less diagnostic of ventricular tachycardia in the setting of a wide QRS tachycardia.
Sir, may I ask?
Okay. Yes.
Sir, in the previous slide, sir,
This one?
Yes, yes, sir. So the pointer which is showing the P wave, sir.
Yes.
Sir, why it is not T, sir? P wave.
Why it is not T?
Yes, sir. Yes.
Okay. So, you know, when you do ECG, you come up with an assumption this is P wave. And then look at the one before. There is nothing like that. Look at the one after. There is nothing like that. Nothing like that, nothing like that, nothing like that. And then there is another one. And that's why I thought this is a P wave. Now, if you ask me, are you 100% sure? No, I can't say that. But look at in this lead also, there is a little distortion here. Can you see it on the top lead? You see the slope, there is a hump here.
Yes.
So most likely this is. So what you do, you just keep following it, and you will find that P wave. And it has to be as a good look, good ECG, good quality ECG. Otherwise, you won't be able to say. Again, look at this here. You could have said this is the end of the T wave, but no, it's a little further out, and it is not present here in the previous RR interval. Okay.
Sir, what can be the clue for juniors who don't understand math ECG? That which one is P and which one is T? Even after looking ECG, sometimes we get confused.
Oh yeah, you compare. If as I told you that if this was a part of the T wave, it would have been present in each of the complex, but it is not. If each complex, let's say each complex had the P wave, then I would not be able to tell you exactly whether it's a P wave or T wave. But the reason I think this is P wave because it is different from the other T waves. So that's the way to find out.
That is there any specific lead, or we should look all the leads for differentiating between P and T? Sir?
Well, in ventricular tachycardia, you are very lucky if you see it in one of the leads. It is tough because if the rate is this one, you can see it because the rate is not that fast. Even this previous one, this one, you can see it because the heart rate is 130. If this heart rate went to 200, there is no way you will be able to see these P waves at all. That's why AV dissociation can be found only in case of ventricular tachycardia with a little bit slower heart rate. Like this one is close to a little bit over 100 beats per minute. That's why you can see it. Otherwise, you won't be able to see it.
Thank you very much. Thank you.
Sure. So this one. Anybody? Again, the heart rate is 135 beats per minute. This is a patient with history of cardiomyopathy and presents with this tachycardia.
Dr. Saifullah.
Dr. Saifullah, is it there?
Yes, sir.
What do you think? So this, I'll give you the heart rate. I have given the heart rate is 135 beats per minute. What do you think?
Sir, the heart rate is 135 and rhythm is regular.
Okay.
And there is underlying right bundle branch block also.
Yes. So what do you think?
And sir,
so underlying right bundle rate 135. Do you think it's sinus tachycardia with right bundle branch block?
yes, sir. It may be.
Okay. Anything else? Any other choice? So this ECG was reported as sinus tachycardia with right bundle branch block by the computer. Sure, in this one, in V1, it looks like a right bundle. In V6, it looks like a right bundle.
Yes,
In
sir.
V1, what it does not fulfill, it does not have the initial R wave, right?
Yes, sir.
There is a Q wave, QR pattern. In lead 1, it is not typical, right? If you remember, in lead 1, right bundle will have a deep S wave. It doesn't have that.
Yes,
So
sir.
that's the only thing that struck me. Otherwise, I would
Any
have thought like you.
one, sir?
What is it?
Is there anything like ST depression in lead 1?
Oh, yes, there is ST depression. Sure. ST lead 1, you can see in V5, V6. But in the setting of a wide QRS, this QRS is 160 milliseconds. This findings becomes kind of irrelevant because like in left bundle, you can see ST depression. That does not mean much. It doesn't mean ischemia. So let's look. What is it? Somebody said something. I couldn't hear you. Okay, who was talking to me at the beginning?
So Dr. Saifullah, probably.
Yeah.
Saiful?
Yes, sir.
Yes. So, okay, let's look at this thing. What we look at, we can also look at the morphology of the QRS complex in lead V1 and V6. And these are the criteria that supports VT. As you saw it, right bundle type, right?
Yes, sir.
In the right bundle type, if it is a QR morphology, it supports VT. This patient, you saw there is a QR, right?
Yes, sir.
And then in V6, if the RS ratio is less than 1. So let's go back here. Again, I have put those criteria. Look at lead V1. There is QR pattern. So with right bundle morphology, wide QRS tachycardia with a QR pattern, it is most likely right bundle. Second, do you remember the other criteria that we said from the beginning of QRS to the deepest point of S wave? I measured it here. It is 110 milliseconds. If it is more than 100, that's VT, right?
Yes, sir.
Those are the two. These criteria are less than S does not fulfill here. It's close to 1. It is not less than 1. So we have two criteria here. Wide QRS tachycardia, right bundle morphology to a QR pattern, that's VT, and beginning of the R wave to the deepest point of S wave more than 100 milliseconds, that's VT. So this one is ventricular tachycardia. We don't have the other criteria, like I cannot see AV dissociation in this one. I'm sure there is P wave, it is buried somewhere. So this I'm going to skip. So look at the again morphology criteria. There are a few other criteria. Again, this one, I think I showed it before. This is a wide QRS tachycardia, and we came to a conclusion of ventricular tachycardia based on beginning of the R to the deepest point of SOA more than 100 milliseconds. But it also has morphological criteria. In lead V1 and V2, if you look at the initial R wave, if it is more than one small box, that's VT. In left bundle type, it will be narrow, less than one box, like this one, more than one box, this one, more than one box. And I expanded V2 here. You can see clearly, right? It is almost close to 2 boxes. And that's ventricular tachycardia. And in V4, I have shown it before, from beginning of the QRS to the deepest point of S wave, it is 130 milliseconds. So no question, this is ventricular tachycardia. The other feature that we use, sometimes if you look in here, let's go back. With the morphology criteria, you have to look in the left bundle type, if there is a hump on this downstroke of lead V1, that supports ventricular tachycardia. Here, anything more than 30 milliseconds, and then this one more than 60 milliseconds with left bundle might block. So this is again ventricular tachycardia. We're just going systematically through this. So if none of this fulfills, then it is SVT. Like this ECG, you can see this is a white QRS. It does not fulfill any of the above criteria. And if you look at the initial R wave, in here there is nothing much, but in V3 there is small R wave. So this is consistent with SVT with left bundle branch block aberration. So if we fulfill, so a lot of things to remember, but you can find this in the books. And the question is that you look at a white QRS tachycardia and then try to analyze what it is. Anybody have any question?
Sir, can you please explain capture bit and fusion bit, please?
Okay. Capture bit is that during ventricular tachycardia, if the P wave conducts and produces a morphology exactly like the sinus P wave, that will be a capture bit. A fusion bit will be if a bit is not VT-like or not like the sinus. I don't have a comparative ECG of what the ECG was in this patient's sinus rhythm, but look at this bit. The beginning part looks like VT, but the terminal part does not. So I made an assumption that this is a fusion between a ventricular tachycardia bit and a conducted bit. How does it happen? If you think of the AV node, the electricity is going down the AV node, and then ventricular tachycardia started by that time, and they collide somewhere and produces a morphology midway between the two. That's a fusion bit. I don't have ECG of capture bit, but in future, if I'm sure I have ECGs like that. I will bring it and show it to you. And this you can find mostly in case where the VT is relatively slow. You don't find it in fast VT. Anybody else? Any other question?
Sorry, in many cases, we find ST depression. When do we consider it as significant?
Okay, in a white QRS rhythm, if you find ST depression, you can't make any comment on that. ST depression is only valid when it is a normal QRS. Then only. Sometimes in the setting of left bundle, you can look at ST elevation or ST depression and compare with the resting ECG. Then only you can make some comment. Otherwise, you cannot. Like this ECG, I'll show you this one. Let me go back. This one. There is ST depression in lead 1, lead V3, V4, V5, V6. This is a white QRS tachycardia. We will not even mention about this at all, because that's an irrelevant thing in this patient. Anybody else?
Sir, I once asked you a question. How to differentiate between BT and SBT with apparent dissociation? Sir, can you discuss it today or later on, sir?
What is the question?
Sir, what is the difference between ventricular tachycardia and supraventricular tachycardia with apparent conduction?
The whole lecture was this. This whole lecture was that. You didn't get it? You see, if it's a white QRS tachycardia, there are only two possibilities. One is ventricular tachycardia. The other is supraventricular tachycardia with aberrant ventricular conduction. And you use this criteria to differentiate between these two. Starting with concordance, then look at the QRS morphology, look at AV dissociation, you look at the morphology criteria, all those things will help you in the differentiating between these two. Any other questions?
Sir, what is meant by extreme axis deviation?
Oh, extreme deviation. We don't use that term. I mean, people use it. If it is more than, some people say more than 120 millisecond, 120 degrees, right or left. extreme left excess. I mean, what's the point of using a term that you cannot define? And so we don't use it. I mean, but most of the time we will not use this term. I mean, it's a term some people do use, but we don't.
Sir, is there any role AVR lead for differentiating or diagnosis VT or SVT in ECG interpretation?
AVR is a problem lead, because where is AVR looking at? AVR is looking from the right shoulder, right? Where does it look? It looks into the cavity of the heart. AVR is not of much use in anything except left main stem obstruction MI. Otherwise, it is not used in differentiating these two.
In day-to-day practice
Yes.
or chamber practice, if the patients come with tachycardia,
Yes.
middle age, maybe diabetic or non-diabetic. So
Yes.
what to do in this situation? Approach.
Well, okay, yeah, sure. So what kind of tachycardia is this? Wide or narrow?
Narrow complex tachycardia.
Okay. Sure. So narrow complex tachycardia, did you listen to my last lecture?
No, sir. Sorry, sir.
You missed it. So we discussed narrow QRS tachycardia. So narrow QRS tachycardia mostly is supraventricular tachycardia. So if the patient is hemodynamically stable, best drug will be to give adenosine to stop it. And if the patient is hemodynamically unstable, then you can do electrical cardioversion. If it is wide QRS tachycardia, management-wise, same thing will apply. I mean, question would be, if the patient is unstable, you don't have to think about it. It is either VT or SVT with aberrant conduction. But if the patient is unstable, you cardiovert the patient. If the patient is not unstable, then you look at the morphology criteria and see whether it's VT or SVT. And if you think SVT, then give adenosine. If you think VT, then make a decision what to do. Most of the time, you will end up cardioverting that patient. But if wide QRS tachycardia, unless proven otherwise, should be considered as ventricular tachycardia.
Sir, Assalamu alaikum.
Yeah.
Sir, what is sustained and non-sustained VT, and what is polymorphic VT, and what is their significance?
Fine. So let's look at this ECG. You answered this one. You asked a question which is pertinent to this ECG.
Yes, sir. There is. I think it is polymorphic VT. No, sir.
It is non-sustained VT with sinus rhythm.
Okay. So sinus rhythm with non-sustained, and you said polymorphic VT. Okay. So I think let's look at it. I have done something. I have removed everything. So when you think polymorphic VT, don't look at multiple lead. You look at one lead. So look at this one. Can you see the P wave here?
Yes, sir.
And then followed by a QRS complex. And then there are bits which are a little different. And then there is a P wave. This QRS is similar to this. So I am making an assumption that this P is a conducted QRS, this conducted QRS from this P. This QRS conducted, and these are little bit narrow, non-sustained ventricular tachycardia. But look at them, they're all looking downward. So this is not polymorphic VT. And, but then the question would be, is it VT or is it just an similar morphology? But no, this morphology is totally different from this one. And then if I go back to this one, look at in this lead V6, the morphology is totally different. So this is not polymorphic VT. This is actually non-sustained VT. Now the definition is, there are two definitions. If a VT is less than 15 seconds in duration, we call it non-sustained. Sometimes some people will call 30 seconds. So it depends on who you are talking to. But majority will, if we are very, very strict, 30 seconds. So any VT less than 30 seconds will be non-sustained. any VT more than 30 seconds will be called sustained ventricular tachycardia. So this one is actually sinus rhythm with short runs of non-sustained ventricular tachycardia. That answers your question, right?
Yes, sir.
Okay.
Sir, assalamu alaikum. Sir, I have a question.
Yes.
Sir, what is normal heart VT and what is its significance? That is, when to treat it?
Oh, so the question is ventricular tachycardia etiology. Majority of the time, ventricular tachycardia is associated with patients who have some kind of structural heart disease. So let's say somebody said a patient diabetic, 65-year-old male. Let me go back. Let me see if there is any history I put here. Usually I put some brief history. So I don't put but this patient, he's 79-year-old. He has history of myocardial infarction. He has ejection fraction of about 30%. That means he has structural heart disease. Now, sometimes we have patients, young patients with ventricular tachycardia who has no history of any other heart disease. That means they don't have cardiomyopathy, they don't have history of those are we call idiopathic ventricular tachycardia. That's a totally different subject. And the prognosis is totally different. Patients with structural heart disease, ventricular tachycardia mortality is very high. Patients with normal heart, which we'll call idiopathic ventricular, their long-term mortality is low. They don't die suddenly. And then their treatment is different. You can use beta blocker as a start. You can use calcium channel blocker. And also you can do ablation. In ventricular tachycardia with structural heart disease, the treatment is different. Most of them will end up needing a defibrillator. Does it answer your question?
Thank you, sir. Okay.
Sure. Anybody else? So let's see if I have something else. What time is it now over there?
Sir, 10:30
Okay. Now this one. So we're going to apply what we learned from this algorithm. Somebody want to do this one? This is the heart rate of 126 beats per minute. QRS duration is about 120 milliseconds.
নতুন কেউ?
Dr. Maruf Hassan. Or Dr. Sharmin Kanta.
Assalamualaikum, sir.
Understand?
Sir, sir, here the rhythm is irregular.
Yes.
And there is absence of P wave.
Okay.
And also there is a wide QRS complex in lead V1.
Yes.
And deep S wave in V3.
Yes.
And also in lead 1.
Yes.
So my diagnosis maybe it may be a case of atrial fibrillation with left bundle branch block.
Yes. So you said atrial fibrillation left bundle, and let's say I say for the sake of argument that this is a ventricular tachycardia. Why do you think this is not ventricular tachycardia?
নমস্কার স্যার।
Yeah,
Dr. Buddhudev.
হ্যাঁ স্যার।
Okay.
Yes.
Sir, there is absence of P wave, rhythm irregular, no capture or fusion beat, and is a typical LBB morphology. So I suggest atrial fibrillation with left bundle branch block, sir.
Yes, and what is typical left bundle morphology?
Sir, typical, sir, white QRS and sir, EM pattern in V5 and V6, or also in EM pattern in 1 and ABL?
Not M pattern. So you are right. In lead 1, wide R wave. But remember, do you remember that criteria that we used the beginning of the R wave? R wave in lead V1, V2, if it is less than 30 milliseconds, that is not VT. This one is less than almost half a box, right?
Yes, sir.
So that is the criteria that you use. So if it is left bundle morphology and you are confused between VT and SVT or whatever, left bundle, look at the initial R wave. If that R wave is less than 1 box, that is not VT. And this one is narrow. And of course, it fulfills the criteria of left bundle, other lead V6. Irregularity goes little bit against, but remember, you can have ventricular tachycardia with irregular RR intervals. So you're right, absolutely. So this patient, this was 5th October 2002, and then when the patient converts previous ECG, you can see sinus rhythm with typical left bundle block pattern. So this is, as I showed, this is a white QRS tachycardia, was a white QRS tachycardia, irregular, but it is just atrial fibrillation with underlying left bundle block. How about this one? Anybody? Rate is about 300 beats per minute.
Sir,
Sir,
can it be a polymorphic VT?
All of you are obsessed with polymorphic VT. If it is VT, is it different shape or one shape?
Sir, one shape, sir.
There is no discordance, all are concordant.
Oh, well, that to know concordance, you must have multiple leads. This I have given you just a rhythm stream. This is lead 2. It is a white QRS tachycardia, rate of 300. The term polymorphic means, poly means multiple morphology, right?
Yes, sir.
This is just single morphology. This is a rhythm strip of a patient in the telemetry floor. Heart rate is 300 beats per. What are you going to do with this patient? What is the first thing you will do?
DC cardioversion.
What is the, anybody else? What is the first thing you are going to do?
So whether the patient is hemodynamically stable or not, I will assess.
How will you know that?
So I will check whether he has pulse or not.
Okay. No,
A carotid sinus message can be given, sir.
Carotid message, sir.
No, just 1 second. You have a patient with a ventricular heart rate of, you think it is 300 beats per minute. What will be the quickest way of finding out if the patient is hemodynamically stable?
So check BP.
Check for carotid pulse.
Blood pressure.
But all of them will take time. Much simpler. Think more simple. Go and ask the patient, are you awake?
Talking to the patient. Yes.
Exactly. First thing you should do is to go and ask the patient if the patient is awake. It cannot be this. Somebody with a heart rate of 300 beats per minute cannot be awake. Look at this. This patient, same time, another lead. What is this? This patient was having this artifact. And if I add another one, patient was in sinus rhythm. But this lead, for some reason, picked up some kind of noise. And you can see this QRS complex over here sometimes, but in this lead, you can see this. So this is actually a common ECG, and this is always given in exam in American Board of Cardiology to find us, for us to find out if we can recognize. Because if you look at this ECG, and if I go rush into the room without talking to the patient is sleeping and I give electric shock, he will not like it very much. So talking to the patient, it helps. All right, how about this one? Who will do this one?
So this is Torsades.
Okay, Torsades. Why do you say that?
Sir, the axis changes.
Sir,
Go a little bit more systematic.
R1 T phenomenon, there is a long QT.
Long QT, prolonged QT.
Okay, sure. So we have P wave QRS, and then there are two premature beats. There's a P wave QRS, and there is a long QT interval in both of them. And then it starts a tachycardia. Why do you call it torsade?
So twisting of point short, long and
Twisting
short.
of the apex. Twisting of the apex.
Yes, look at this. This is looking up, right? And then it is looking down. And then it should look up again. But after that, this tracing becomes very difficult. But one of the criteria, most of the time, here it almost looks like ventricular flutter or ventricular fibrillation, but it stops turning. So you are right. The diagnosis is torsade. So, but when you describe this ECG, please go systematically. Sinus bradycardia with ventricular couplet followed by a run of torsade. How will you manage this patient?
Sir, give magnesium sulfate. Then, sir, DC cardioversion.
Okay. Why will you do DC cardioversion?
Sir, DC cardioversion, sir, Torsades de Pointes is, sir, malignant type arrhythmia. Most of the patient is, sir, hemodynamically unstable. So I prefer DC cardioversion.
Yes, but look at this. This tachycardia stopped after a few seconds. So if I cardioverted the patient here, it may come back again. So most of the time, torsade will terminate itself unless it degenerates into VF. So you don't have to DC shock every torsade. Just wait a few seconds to see if it comes back. But treatment-wise, you give magnesium sulfate. What other condition we give magnesium? Do you remember?
Preeclampsia, bronchial asthma.
Yes. Why? Why do we give magnesium in preeclampsia? It stabilizes the membrane.
Yes, sir.
So it doesn't. Yes, and it prevents arrhythmia. What else will you do with this patient? One more.
Check the serum electrolyte. Took the drug
Let's
history.
electrolytes are fine in this patient.
Check. Ask for drug history.
The patient is not taking any drugs. But treatment-wise, what other treatment? What?
Any disease condition?
No. This is a 47-year-old male, no other problem. But treatment-wise, you give magnesium. What else will you do to prevent this happening again and again?
Sir, amra ICD, sir,
ICD implantation.
Cardiac gangliosectomy.
Well, no, ICD implant, you cannot do the ICD immediately. Patient came to the emergency.
Calcium channel blocker.
Okay, no. Look at
Beta blocker.
Okay, look at this, how it started. It started with
ventricular
a pause.
ectopics.
Ectopic and a pause. Look at the QT interval, how long it is. But look at here, this 2 beat. They are faster, right? How is the QT here? Long or short here? In where my pointer is. What is the QT interval here? Short or long? Short.
Short, sir.
What happens? Bradycardia makes the QT long. If you can make this patient tachycardic, QT will become short and it may be able to prevent the torsade. So what you do? You can give drug to increase the heart rate like isoprenaline or put a temporary pacemaker in. And then, as you said, if there is any reversible cause, just wait for that to go away. Like if you have given some kind of antibiotic that can prolong QT, or you fix the cause of bradycardia. This patient, you see, when the heart rate is 63, QT was 640 milliseconds, this length. And when we and the heart rate goes up, this is a different patient. The QT is shorter. So this is similar, same thing. This patient, this is a patient, 83-year-old female. Then you can see that she had a pacemaker which malfunctioned. So it became bradycardic. There is two PVCs, and then there is a long QT followed by torsade again. And this patient, we just fixed the pacemaker and she did fine. Anybody wants to do this one? Again, we're talking about just white QRS tachycardia.
Dr. Sabbir.
Why is Dr. Sabir? Anybody just where is Noshin today?
Sir, existed antidromic EF.
Okay. So this is a white QRS tachycardia, right?
Yes, sir.
Is it regular or irregular?
Irregular, sir.
Irregular. And so what is your diagnosis?
Sir, existed antidromic EF with WBW syndrome.
Okay.
White tachycardia, grossly.
With what? Actually, your diagnosis is correct, but I will not use antidromic because when people have atrial antidromic or orthodromic tachycardia is used for in case of supraventricular tachycardia. But this actually is very irregular. And your diagnosis is correct that patient probably has atrial fibrillation with conduction through the accessory pathway, giving rise to the white QRS tachycardia, which is irregular. Why not non-sustained ventricular tachycardia? I can, for argument's sake, I can say this is normally conducted QRS, then there are a couple of extra beats, and then non-sustained VT. Why not? How do I know that this is AFib with irregular with WPW? Anybody, any criteria, idea? One of the things you look at, if you look at the QRS duration, what do you think of the QRS width here? This one?
Delta wave presence.
No? Are you sure it's delta wave? I'm just think a little bit more simple. Is the QRS duration same or irregular in this QRS?
It is irregular.
Irregular. Remember, if you find a white QRS tachycardia with irregular RR interval, and the QRS width is also irregular, different. Each QRS width is different. That is WPW syndrome with atrial fibrillation. This ECG, if you look at here, this is wide, this is less wide, this is a different width, right? Each of them are different. So same patient. So this is another one. Look at this. This is actually a better one. You can see the difference here. Wider, less wide, a little bit more. Each QRS is different width in the same lead. You have to look at the same lead and irregular RR interval. And this is WPW. And this patient, when the patient converts to sinus rhythm, now you see the pre-excitation here. During atrial fibrillation, to use the term pre-excitation is very difficult. You cannot use that term because you don't know where the beginning of the QRS is or where is the delta wave. But delta wave can only be defined during sinus rhythm. So did you understand this ECG or any question, confusion? No? Okay. So, all right, I think we have done enough today, unless you have any other questions.
আর কারো কোনো কোশ্চেন?
স্যার আরেকবার একটু বলবেন স্যার টোরসাডের দি পয়েন্টস কিভাবে আর কি আইডেন্টিফাই করব?
Torsade?
কেমনে আইডেন্টিফাই করব?
Yes, okay. Let's go back. So first of all, a wide QRS tachycardia, which changes its morphology, twists around the point, and then terminates spontaneously, and preceded by, most of the time, long QT interval. So that's typical finding for Torsade. This ECG, I don't have the ending of it, so I cannot say it is ended, but it definitely ended, this patient also, because she was alive. So you see that it looks up. This is difficult to say whether it's looking up or down because it's such a funny looking wave, but you see there it morphology becomes narrow here. So this is more typical of a Torsade ECG. Sorry, I went the wrong direction. Self-terminating wide QRS tachycardia with twisting morphology preceded by long QT interval.
থ্যাংক ইউ স্যার।
আমার স্যার একটা কোশ্চেন ছিল স্যার।
Sure.
স্যার capture beat, fusion beats are most important feature of sir ventricular tachycardia, but sir some ECG irregular caption beat, fusion beat present. Although we said atrial fibrillation, but sometimes irregular capture beat, fusion beat present, we say ventricular tachycardia. Sir, these are most confusing, sir. Someone say atrial fibrillation, sometimes say ventricular tachycardia.
You have to, so when you have to bring those ECGs. What you can do, if you have any ECG like that, bring it to this forum, just send it to me and we can discuss it. Because to remember one thing, that you can, the way to learn things will be that you learn, keep learning in a systematic way. And you, it is like driving or riding a motorcycle. What you do, if you can drive at a low speed for 2 years, then you will become an expert driver without an accident in future. And you will actually know. Same thing with ECG. Keep learning, learn simple ones, difficult ones, keep learning, and then forgetting, keep learning, forgetting, but then eventually you know all those things. But also if you, whatever situation you were telling me, if you have the ECG, then it's easier to discuss.
ডক্টর মাহমুদুল হাসান কিছু বলবেন?
Yes, sir. If no one has any question, then I have a comment to make, sir.
Sure, please do.
Sir, I am from Rajshahi Medical College, sir. Sir, I have heard many stories from about you, Mahmoud Hassan, sir, and many others like you, sir. From Charu Mama, sir. Probably you accompany him, sir.
Yes, definitely.
Sir, he died, sir, but we had many, when we were students, sir, we had many things about you, sir. Sir, actually, you are, I'm very proud as RMCN and as Bangladeshi that you belong to our institution and from our country. And
Thank you.
what you are doing and the sessions you are taking are beyond imagination, and we never had such opportunity to undergo before, sir.
My pleasure.
Best of luck, sir. Please continue such sessions and please take care of yourself, sir. Thank you very much.
Sure, thank you very much. Thank you.
স্যার একটা কোশ্চেন নিয়ে নেই স্যার ডক্টর শফিকুল ইসলামের। হট ড্রাগ টু বি ইউজড ইন টারশিয়ারি মেডিকেল কলেজ ইফ এ পারসন কামস উইথ এফ উইথ WPW?
Oh, okay. So the question is, this patient, okay, let me bring the ECG. This patient in the emergency room, heart rate is close to 300 beats per minute and WPW syndrome. So normal atrial fibrillation with rapid ventricular response, I will give drugs like digoxin, beta blocker, or calcium channel blocker. The problem will be in this patient, the conduction is going through the accessory pathway. And if I give this patient beta blocker or block the AV node, it will make things worse. Best drug for this patient is procainamide. Unfortunately, procainamide is so infrequently used that it's no longer available even in America. And so the alternate drug, people have used amiodarone, but there is some data that amiodarone can cause precipitate ventricular fibrillation in this patient. I think even though it does, the incidence is not high in the absence of procainamide, probably amiodarone is the second best drug. The other choice would be, if the patient is unstable, just electrical cardioversion. The problem with electrical cardioversion, because this patient is in atrial fibrillation, if it is an older patient, you always think about risk of stroke. So that's the problem. So procainamide is the best drug for this patient.
Sir, but it is not available in Bangladesh. Then what should?
Then you use amiodarone. I mean, the thing about amiodarone will be that, yes, they say there is some data that it can produce ventricular fibrillation. But if you do it in telemetry monitor, I think majority of the patients are going to do well. I think that's the only alternate drug that you can use. There is no other, because you have to give something which is intravenous in this patient with rate so fast. Amiodarone will be the drug to give intravenously.
Thank you, sir. Thank you.
Thanks.
Assalamu alaikum, sir.
Sam?
So I want to say, the patient having pacemaker,
yes.
and if the presents with white complex tachycardia, then
yes.
How to interpret the ECG? What to think about that?
Okay, the question is, somebody with pacemaker develops ventricular tachycardia. At that point, there is no pace beat, right? If the patient with pacemaker develops ventricular tachycardia, there will be no pacemaker spike. So pacemaker becomes irrelevant in that case. However, if you see pacing spike before each QRS complex and what you think is ventricular tachycardia, then it is not ventricular tachycardia. Either the pacemaker is tracking a supraventricular rhythm and producing a white QRS, or it can be pacemaker mediated tachycardia. Usually pacemaker mediated tachycardia will be right around 120, 130, which is the upper program rate of the pacemaker. So those are the three situations where you will see white QRS tachycardia in a patient with pacemaker. Does it answer your question?
Sir.
আমার মনে হয় স্যার আজকে আর আমরা কোশ্চেন আনসার সেশন স্যার শেষ করে ফেলি স্যার তাহলে।
Sure. Okay. All right. Thank you all.
স্যার থ্যাংক ইউ ভেরি মাচ স্যার। আর বাকি অডিয়েন্স যারা আছেন তারা একটু থাকবেন স্যার চলে যাওয়ার পর, আপনাদের সাথে আমি একটু 1 মিনিট কথা বলবো আমাদের 10 তারিখের একটা ইভেন্ট নিয়ে।
ওকে।
আচ্ছা নেক্সট ফ্রাইডে ইনশাআল্লাহ আবার দেখা হবে স্যার।
Sure.
জি স্যার। থ্যাংক ইউ ভেরি মাচ স্যার।
Thank you.